Hello everyone, my name is Samuel and I'll be taking you through the adrenergic pharmacology. So let's delve into it. This is our outline for the presentation. Okay, so let's look at an overview of the sympathetic nervous system. The nervous system, being one of the important systems in our body, is divided into the central nervous system and the peripheral nervous system. The peripheral nervous system is divided then into somatic, which is under voluntary control of the brain, and then autonomic, which is involuntary. So that one is reflex action. Okay, the autonomic nervous system is divided into two. We have what we call the sympathetic nervous system and the parasympathetic nervous system. Okay, now the sympathetic nervous system is the fight or flight response, and the parasympathetic is the rest and digest system. Our main focus for this presentation is the sympathetic division, and it originates from the thoracolumbar region of the spinal cord, that's specifically T1 towards L2. Okay, anatomically we have preganglionic neurons and then postganglionic neurons. A ganglion is just a collection of nerves outside the central nervous system. Okay, so a preganglionic neuron is the one that supplies the ganglion, and the postganglionic neuron is the one that takes from the ganglion. And for the sympathetic nervous system, the preganglionic axon is very short compared to the postganglionic axon, as you can see in the diagram here. And then compared to that, the parasympathetic nervous system is having a very long preganglionic axon and a short postganglionic axon. Now, between the preganglionic and the postganglionic neurons, you realize that there is the release of what we call neurotransmitters, which are like chemical messengers. Okay, now the neurotransmitter that is released at all synapses is the acetylcholine. Okay, between the preganglionic and then the postganglionic, we have acetylcholine, but then we have the postganglionic to the effector organ. What is released in the case of sympathetic nervous system is norepinephrine, also known as noradrenaline. Okay, now, like you said, the preganglionic fibers release acetylcholine, and that would in turn act on nicotinic receptors. But then the postganglionic fibers release norepinephrine, and those act on adrenergic receptors. The adrenergic receptors could be alpha and beta receptors. Okay, now there's a one exception that you have to take note of. The sweat glands, even though they belong to the sympathetic division of the nervous system, are innervated by parasympathetic fibers. Okay, and then we also have the adrenal medulla. The adrenal gland is only supplied or mainly supplied by a preganglionic neuron. So there's no postganglionic neuron, only preganglionic neuron, and it releases acetylcholine, and that will cause the adrenal medulla to also release epinephrine and norepinephrine to have them producing the effects that we desire. Okay, now the effector organs for the sympathetic division and autonomic nervous system in general is smooth muscles, the cardiac muscles, and glands. And the primary effect is that when norepinephrine binds to receptors on the heart, it tends to cause the heart rate to go up, and so the heart will tend to be pumping a lot of blood. And in the airways, the sympathetic response is that there is bronchodilation. How I remember this is, I imagine you encountering a wild animal like a lion, okay, and at that particular instant, your body tends to respond by various changes. And one of the changes is that your airways tend to open wide, like it dilates. So there's what we call bronchodilation, so that there will be more air entry. So you tend to breathe in very fast, okay? And then you will see that at that particular instant, too, your heart will be pumping very, very fast. And that is because your blood is being pumped to your extremities to provide the needed energy for you to take off. That is the flight, response. Okay, at that particular instant, to your eyes open very wide so that you'll be able to see, is what I have in front of me a lion or not? So there is what pupillary dilation. And then there, you don't have time to think about the food you ate in the morning when you encounter a lion alone. So the decrease what GI motility. Likewise, glycogenolysis and lipolysis increases because we need enough energy to be able to what, take off or fight the lion. So those are the primary effects of what, the sympathetic nervous system. Okay, so now let's delve into the receptors. So there are alpha receptors and beta receptors. There are also dopamine receptors, but here we'll be talking more often about the alpha and then the beta receptors. They are all G protein coupled receptors. What it means that they are what, metabotropic, and it means they require secondary messengers before they will provide the desired outcome that we want. Okay, now, when you take the alpha receptors, mostly we have two divisions for each alpha, and then for the alpha receptors, we have alpha 1 and then alpha 2. Alpha 1 receptors are located on the vascular smooth muscles, so on the blood vessels, and then the iris and then bladder sphincter. So on the blood vessels, they tend to cause vasoconstriction, so they constrict the blood vessels, so that would in turn also affect the BP. Okay, there's also pupillary dilatation, like we mentioned, and then the bladder contraction. So that's causing of urinary retention. Then there are GQ protein um, receptors, in the sense that they tend to increase the levels of what inositol triphosphate, and that is agnestrol, which will in turn increase the intracellular calcium ions. All right. Then we have the alpha 2 receptors, which are found mainly on postsynaptic nerve terminals, and also the central nervous system, as well as platelets and the pancreatic what, beta cells. So what they do is that they inhibit norepinephrine release. Okay, and they also there's also CNS inhibition, and that will also in turn cause what, decrease in insulin or secretion once you have um, agents binding to this. They are GI, that's the inhibitory G protein coupled receptors. So what they do is that they tend to decrease the cyclic AMP levels. That will in turn decrease what, cellular activity. Then we have the beta receptors. There are three of them. We have beta 1 receptors, beta 2 receptors, and beta 3 receptors. Beta 1 receptors are located on the heart. Okay, so I said we have only one heart, so beta 1, 1. Beta 2 receptors are located on the lungs, so we have two lungs. All right. When you have norepinephrine binding to these beta 1 receptors, they tend to cause chronotropy, so increase heart rate. The heart would also contract, so inotropy, and there is increased renin release, and that would in turn what, raise the blood pressure. These ones are stimulatory, they have a stimulatory effect, so we have GS protein. They tend to increase the cyclic AMP levels. Then we have beta 2 receptors, which are located on the bronchial smooth muscles and then vascular smooth muscles. Okay, you can also find them in the uterus and then the liver. On the bronchial smooth muscles, they tend to what, cause bronchodilation. There's vasodilation when they act on the skeletal muscles, and there's what, uterine relaxation. And remember, they also are stimulatory, so they tend to cause increased cyclic AMP levels, and that will increase cellular activity. So glycogenolysis and gluconeogenesis would also increase as well. Then we have the beta 3 receptors. Beta 3 receptors, the way I like to remember them is that when you take fats, there are three letters, FAT. So these are found on what, fatty tissues or adipose tissues. And then you can also have them on the gastrointestinal tract or the GIT. Okay, so we have bladder detrusor muscles to having beta 3 receptors. The effect is that they tend to cause lipolysis and then bladder relaxation. Right. So this is what I meant by GQ protein receptors. They tend to stimulate the action of phospholipase C, and that would then increase the action of what, inositol triphosphate, which would in turn increase calcium ion levels, and calcium is responsible or needed for what, smooth muscle contraction. Then we have the stimulatory ones that will go through secondary messengers like adenylyl cyclase, that would in turn increase the cyclic AMP levels, which would tend to activate the protein kinase A, and that is also going to in turn cause for cellular activity to what shoot up. Okay. Now, how are these catecholamines, norepinephrine and epinephrine, synthesized in the body? So the synthesis pathway is that most of them occur in the nerve terminals, and what we need to synthesize this is what tyrosine. Remember, we also said that adrenal medulla can also release norepinephrine and epinephrine, but then we can also synthesize some of them at the nerve terminals. Okay, so take note of the main pathways. Tyrosine is converted to dopa by tyrosine hydroxylase, and this dopa uh, is in turn metabolized by dopa carboxylase, which is an enzyme to dopamine. Then dopamine would be acted on by dopamine beta hydroxylase to what? Norepinephrine. Now, sometimes we want to convert norepinephrine to epinephrine. We utilize an enzyme called phenyl ethanolamine N metatransferase as PNMT that will convert it to what? Epinephrine. And this occurs mainly in what? The adrenal medulla, which is stimulated by what? Cortisol. Now, once it is once we've been able to what? Produce the um, norepinephrine that we need. So this is what I meant. Tyrosine cross into the cellular membrane. Inside is the cytoplasm. Then it's acted on by tyrosine hydroxylase into dopa. Then dopa is in turn converted to dopamine. Then you have dopamine being converted to norepinephrine. Now the norepinephrine is stored in what? Vesicles with the help of what? A VMAT. Okay, it's stored in vesicles, and when we have enough or adequate norepinephrine, then they will come and fuse with the membrane, and then they are exocytosed out into the synaptic cleft. Now, before the exocytosis, there are things that we need to take note of. There is the opening of voltage-gated calcium channels that would cause calcium influx, and this is also going to help in the fusion. There are also snare proteins, that the snaps that you see here, which helps in what? The fusion, and that would in turn cause what? The exocytosis, and then we have norepinephrine being released. Now, once the norepinephrine is released, it can bind to the adrenal receptors, that is the beta receptors and the alpha receptors, or it can be taken back through an autoreceptor. Okay, we call it reuptake 1, or through NET back into the nerve terminal. And this is very, very important for you to take note of. So let's go through them again. So the release is by the action potential and calcium influx, causes exocytosis. Presynaptic alpha 2 receptors would inhibit what? Norepinephrine release, as we talked about. Then the presynaptic beta 2 receptors enhance what? Norepinephrine what? Release. Okay. The termination is that the action is that there is reuptake by a norepinephrine transporter, that's the NET, into the neuron, and this can be inhibited by drugs like cocaine and tricyclic antidepressants. And norepinephrine, once it's also left in the synaptic cleft, can be metabolized by enzymes like monoamine oxidase and then catechol O metal transferase, which is mainly found in the liver. Okay, the final metabolite that is formed is what? Vinyl mandelic acid. Okay, we can also have metanephrine and then normetanephrine. What happens is that they diffuse away from the synaptic cleft. So you can see that there is diffusion here. And I said that the NET is also inhibited by cocaine or tricyclic antidepressants like imipramine. Then we have drugs that can inhibit the snare proteins. We have bertilium and then guanidine. Okay. We have those that can inhibit the enzymes. When you take tyrosine hydroxylase with tyrosine, okay, or metadopa can inhibit that enzyme. We have recipe that inhibits the norepinephrine from moving into the vesicle. So what it does is that it tends to like replace or displace the norepinephrine from the vesicles, and so there will not be any vesicles there. What we'll be having is what? Recipe. Okay, so let's move on to drugs that act like um, norepinephrine. That those ones are called direct adrenergic agonists. What they do is that they produce the same effect as when norepinephrine binds to the receptors, and these agents could be selective or non-selective. We have non-selective agonists. Whenever you see epinephrine, take note, it binds to everything, everything. Okay, epinephrine acts on alpha 1, alpha 2, beta 1, beta 2. So we use it in anaphylaxis, cardiac arrest, and in asthma patients. All right. What it does is that when it binds to the beta 1 receptors of the heart, it causes what? Heart rate to shoot up, and then there's what? Contractility. When it binds to beta 2 receptors of the lungs, causes bronchodilation. When it binds to alpha 1 receptors of the blood vessels, it causes what? Vasoconstriction. When it binds to the smooth muscles of the skeletal muscles, then we get what? Vasodilation. Okay. Then there is what? Norepinephrine. Norepinephrine itself um, acts on mainly alpha 1, alpha 2, and beta 1. There is minimal action on beta 2, so rarely would you see um, norepinephrine binding to the beta 2 receptors of the lungs. Okay, so we use it in the treatment of hypotension and then septic shock. If the patient is in septic shock, there is a lot of infection, then you would want to use norepinephrine too. It's a strong vasoconstriction and it gives a modest increased heart rate. Then there is dopamine. Dopamine is dose dependent. Remember I mentioned that there is also what? Dopamine receptors. Dopamine receptors, D1 receptors are the one that we need for this presentation. And these ones are found on the bladder. Okay, so D1 receptors, they also tend to cause what? Renal vasodilation. So blood vessels supplying the kidney would what? Vasodilate, and then there's moderate effect on beta 1 that they tend to increase heart rate and contractility. But then the dopamine can also have an effect on alpha 1, which is what they tend to cause what? Vasoconstriction, and we use it in the management of shock and what? Heart failure. Then there is isoproterenol, also known as isoprenaline. This one is it binds equally to beta 1 and beta 2 receptors. Okay, so beta 1 and beta 2 non-selective. This tends to cause use in the bradycardia and AV block. Okay, then we have drugs that are selective. So we have selective alpha 1 receptors, selective alpha 2 drugs, and then selective beta drugs. Selective alpha 1 drugs are phenylephrine. This one is used in nasal decongestion and hypertension and mydriasis. Okay, mydriasis, and then the effect is that it can cause vasoconstriction. Okay, remember that alpha 1 receptors, once we have anything that is mimicking the action of norepinephrine, it will cause the vessels to what? Constrict. Alpha 1 blood vessel constrict. Okay, then we have clonidine and then metadopa. Metadopa is used in managing hypertension in pregnancy. This is something you want to remember in exams. Metadopa for what? Managing hypertension in what? Pregnancy. Then we have clonidine. Clonidine is centrally acting. It acts on the alpha 2 receptors as an agonist and is used in the management of hypertension and opioid withdrawal. Okay, the effect is that it tends to decrease sympathetic outflow in the central nervous system. Then we have selective beta agonists. We have drugs that will bind selectively to beta 1 receptors. Alright, we'll talk about them, but the main agent here I want you to take note of is what? Dobutamine. Dobutamine is used in acute heart failure and cardiac stress testing, and this tend to what? Because it's binding to the heart, there's increased heart rate and there's what? Increased what? Contractility. Salbutamol, also known as albuterol and terbutaline, are what is used in asthma management. They bind to beta 2 receptors to cause what? Bronchodilation, and then the smooth muscles will tend to what? Relax. Then there is what? Mirabegron, which is acts on beta 3 receptors of what? The bladder. So if we have an overactive bladder, we tend to give this agent to cause what? The bladder detrusor muscles to what? Relax. Okay. Now another agent that you want to also take note of is what? Phenodopam. Phenodopam is a dopamine receptor agonist and is selectively for D1 receptors. And remember I said that it causes what? It causes arterial vasodilation, especially in the kidneys, and then there is increased renal blood flow, which would promote natriuresis and diuresis. Okay, it does not stimulate the alpha or beta receptors. We use it in hypertensive emergencies in some cases, especially with renal insufficiency. We administer them via IV. The side effects is that cause headache, flushing, hypotension, and reflex tachycardia. Phenodopam is an agent that you want to remember in the exams. So how do you remember? Phenodopam. So I've removed the do and then make it what? D1 receptors. Okay, so phenod D1 pump receptor. Think of D1 action and kidney friendly what? Vasodilation. Okay, so we have adrenergic agonists. This is what I talked about. There is the direct acting and there is what? Indirect acting. Direct acting ones could be selective or non-selective. Selective, we have alpha 1 selective, alpha 2 selective, beta 1 selective, beta 2 selective. Then we have the non-selective ones that binds to everything. Mixed acting ephedrine is another agent that you want to remember. Ephedrine binds to alpha 1, alpha 2, beta 1, beta 2, and is also a releasing agent. So that differentiates ephedrine from epinephrine. Epinephrine is not a releasing agent, but ephedrine is a releasing agent. Take note of that. Then we have the indirect acting agents. The releasing agents, we have amphetamine and then what? Thiamine, which are tricyclic antidepressants, and I already told you that they inhibit what? Uptake 1, like that of cocaine. Then we have the MOA inhibitors, which are salicylic, and then we have the COMT inhibitors and tacapone. Alright, so the indirect acting agonists are the ones that do not bind to the receptors, but they increase the levels of norepinephrine at the synaptic cleft. And how they do that is that they promote the release of the stored catecholamines. So if you take a drug like amphetamine, it increases norepinephrine and dopamine release. It also inhibits the MAO enzyme. Okay, so we use it in attention deficit hyperactive disease and then narcolepsy. Then we have thiamine. Thiamine is found in fermented foods, and I want you to remember thiamine found in what? Aged cheese. Normally, the thiamine is metabolized by MAO, and then can cause hypertensive crisis in patients who are on inhibitors. Okay. Then we have those that inhibit the reuptake of catecholamines, and cocaine, like I said, blocks the norepinephrine transporter and dopamine transporter as well. This will cause increased levels of norepinephrine and dopamine in the synaptic cleft, and we use it in local anesthetic conditions, especially in ENT procedures, and they tend to cause severe hypertension and arrhythmias. Okay. Then we have the tricyclic antidepressants like imipramine. They also block the NE reuptake and is mainly used for depression. Okay. Those that inhibit the catecholamine degradation, MOA inhibitors, salicylic, we have already mentioned. There's also phenazine, which is non-selective. Then we have the COMT inhibitors and tacapone, we've already mentioned, used in Parkinson's disease. There's guanidine, which is adrenergic neuron blocker. Okay. Another one is bertillon. Guanidine is a peripheral sympatholytic. It enters the adrenal neurons via norepinephrine transporter. And remember, I said that it would displace the norepinephrine from storage vesicles, and that will prevent its release. Okay, so it leads to degradation or depletion of norepinephrine from the sympathetic nerves. It can cause vasodilation and decrease blood pressure. Now, guanidine was used in the management of hypertension formerly, but then we don't use it. It does not cross the blood-brain barrier, so it doesn't produce any central nervous system effects. But the side effects that causes orthostatic hypotension, diarrhea, and it has been found to also cause of sexual dysfunction. And The interaction is that it interacts with tricyclic antidepressants, so you don't want to give the two together. Okay. Then we have adrenergic antagonists. These are agents that will block the effect of catecholamines. So it's either by inhibiting the alpha or the beta receptors. It binds to those receptors. So we have alpha selective and non-selective. Then we have beta selective and non-selective. Alpha adrenergic antagonists. We have non-selectives, phenozibenzamine and then phentolamine. These are agents that I want you to remember. Okay, phenozibenzamine is irreversible and it is used in the treatment of what? Pheochromocytoma. Now take note of this. Phenoxybenzamine has 11 letters. Pheochromocytoma has 11 letters. Okay, and so you want to remember that phenoxybenzamine, which is very long, is used in the pheochromocytoma, which is also very long. So the side effect is that it causes orthostatic hypotension and then what? Reflex tachycardia. Phentolamine is reversible. So if a patient is on MAO inhibitor and then he eats a lot of what? Cheese or thiamine containing foods, and you want to also give these agents to reverse the effect. Okay. Then selective alpha 1 blockers are the ones that end in sin. Okay, so we have prazosin, doxazosin, terazosin, tamsulosin. Okay, these ones are used in the management of urinary symptoms, especially in benign prostatic hyperplasia. You would want to use tamsulosin. Okay, and then we have PTSD, which is post-traumatic stress disorder. We use prazosin. Then hypertension. Sometimes we can use all the other agents, but we don't want to use tamsulosin in hypertensive patients. And side effects is that they all tend to cause what? Orthostatic, first dose orthostatic what? Hypotension. Selective alpha 2 blockers are yohimbine and then metazapine. They all block the 5-HT2 HT3 receptors, and they tend to cause what? They are used in depression, especially with insomnia or what? Low appetite. Now let's talk about the ones that affect the beta receptors. We have non-selective and then the selective ones. The non-selective beta antagonists are remembered with the alphabetical letters, the one that start from N to Z. Okay, they are the second generational beta blockers. And so we have propanolol, timolol, nadolol. Okay, anything that starts from N to Z, you want to remember that they are non-selective and they are second generation. They are first generation drugs. Okay, then we have the beta 1 selective, which are cardioselective. Those ones are from A to M. Okay, so atenolol, esmolol, metoprolol, from A to M. You want to remember that these ones are what? Beta 1 selective. Okay, they are second generational agents, and then the non-selective ones are first generational. Okay, these ones are used in hypertension and then heart failure, angina, and then arrhythmias. Then non-selective agonists plus alpha 1 blockers have been found in these agents labetalol and then carvedilol. So they have modified surfaces. Instead of olol, you can see that labetalol, ALOL. Then we have what? Dilol, ILOL. Okay, so these ones, what it means is that they are non-selective and they also have effect on the alpha 1 receptor. So they block alpha 1 receptors as well. So labetalol is used in hypertensive emergencies and then carvedilol for heart failure. Now there's another agent I want you to take note of, nebivolol. It has combined, remember it's what? A non-selective. It has combined cardioselective beta 1 adrenergic blockade and then stimulation of beta 3 receptors. It also activates the nitric oxide synthase in the vasculature, and so it tends to cause the release of nitric oxide. So I want you to remember nebivolol. The N and the O in it signifies that there is what? The NO or nitric oxide releaser, or it increases the levels of nitric oxide. Okay, now let's move on. So this is what I mean by the adrenergic receptor antagonist. So we have alpha receptor antagonist, and then we have beta receptor antagonist. We have selective and non-selective. Non-selective alpha antagonists are phenoxybenzamine and phentolamine. Phenoxybenzamine, pheochromocytoma. Okay, then we have phentolamine, which is what reversible. This is also irreversible. So all the long letters for phenoxybenzamine. Then we have alpha 1 selective. So all the sins: prazosin, terazosin, dorazosin, alfuzosin, tamsulosin. Okay, then alpha 2 selective, we have yohimbine. Then we come to the beta antagonists. We have the non-selective ones: nadolol, penbutolol, pindolol, propranolol, timolol, sotalol. Remember, I said that these ones start from what? N to what? Z. These ones are first generation. Then we have the beta 1 selective. These are second generation. So A to what? M. Azibutolol, atenolol, bisoprolol, esmolol, metoprolol. Then the non-selective third generation drugs, remember I said they have what? Combined effect. So they tend to also block alpha 1 receptors. Example is what? Carvedilol and what? Labetalol. Remember A law, D law. So there's no O law in it. Okay. Then we have beta 1 selective, which are third generation also as well. Betaxolol, celiprolol, and then nebivolol. Nebivolol, remember I said that the N and the O for nitric oxide release. Okay. So if we have adrenergic agonists, a lot of them, and then prolonged use is going to cause increased heart rate, so tachycardia and palpitations, and they will tend to bind to the alpha 1 receptors of the blood vessels. To constrict it, that's also going to cause what? Hypertension, it causes arrhythmias, anxieties, tremors, and then there is also what we call rebound congestion with chronic phenylephrine use, and then it can also lead to hypertensive crisis. That's when you give theramine in MAO inhibitors. Okay, adrenergic antagonists, like when you block alpha receptors, you have effects like orthostatic hypotension, reflex tachycardia, and nasal congestion. Okay, remember what agents is used for nasal decongestion? Phenylephrine. So you use phenylephrine to reverse this. Okay, so we have alpha blockers, they cause bradycardia because they are lowering the heart rate. There is bronchospasms, so it causes the bronchial areas to constrict. You don't want to use them. There is fatigue, depression, masking of hypoglycemia symptoms. This is one important thing you have to take note of, that beta blockers mask hypoglycemia in diabetes. So you have to use beta 1 selective agents if the patient also has asthma or COPD. Okay, the sudden withdrawal is also going to cause rebound hypertension or angina. All right. Now, this is another thing that I want to talk to you about: beta blockers that come with intrinsic sympathomimetic activity, and these are the ones that partially activate beta receptors while blocking full agonists. They act as partial agonists and they exert mass stimulation while preventing stronger endogenous catecholamine from binding. And the examples are pindolol, acebutolol, cartilol, oxprenolol, and celiprolol. These agents are things that you can remember. I mean, they even the ones here are PACOC, okay? Pindolol, acebutolol, cartilol, oxprenolol, and then celiprolol. These ones have intrinsic sympathomimetic activity. They are useful in hypertensive patients with bradycardia, as they don't significantly lower their resting heart rate or cardiac output, and they are less likely to cause severe bradycardia and fatigue. They are not ideal in the management of angina or post-myocardial infarction of patients. Okay. Now, some of these agents are water soluble, and so it makes it less likely for them to cross the blood-brain barrier. And these ones are atenolol, celiprolol, nadolol, and satolol. Remember them too as well. Okay. Now, the next one we look at is adrenergic pharmacology, VET. All these drugs that we've mentioned, most of them are used in what? Veterinary medicine. If you take something like epinephrine, epinephrine is used in what? Anaphylaxis, or if a patient comes and is having cardiac arrest, we use it in veterinary medicine. Norepinephrine too is also used. Vitamin is a positive ionotrope and is used in acute heart failure in dogs and cats. Why? Because it improves their cardiac output without any major changes in the heart rate. Dopamine is used to treat shock and renal perfusion failure in these animals. Then we have phenylephrine too is also used for nasal congestion, like I mentioned, in horses and dogs. Sometimes it's used in ophthalmic surgery to dilate the pupils without any cycloplegia. Cycloplegia is when the eyes are unable to accommodate. Then there's clenbuterol, which is also a beta 2 agonist used for bronchodilation. In horses, there's terbutaline, which is used as bronchodilator. In cats and dogs, there's xyloxine. The vets, you want to remember this drug because it appears in liaisons a lot. So it's an alpha 2 agonist used as a sedative or analgesic in horses, cattle, and all small ruminants. Then there's the antagonist. We have yohimbine, which is an alpha 2 antagonist. It's used to reverse the sedation from what? Xyloxine. Okay. Then there's propanolol, atenolol, which is used in the management of cardiac arrhythmias in dogs, and then can also be used in thyrotoxicosis. That's when you have high levels of thyroid hormones in especially cats. Then we have prazosin, which is an alpha blocker, is used in cats and dogs with what? Urethral obstruction or what? Hypertension. Then we have carvedilol, which is used in what? Canine heart failure. So xylazine, like I said, is emetic in cats but not in dogs. You want to take note of it. And specific dosing is very crucial. Beta 2 agonists in food animals are strictly regulated or banned due to what? Residue concerns. Okay. Also, you have to consider some of the withdrawal periods for these agents in food producing animals. So, in summary, we talked about adrenergic pharmacology. We have agonists and then we have antagonists. The agonists could be alpha 1 or alpha 2. Alpha 1, we have phenylephrine and as a main agent. Alpha 2, we have clonidine, metadopa using hypertensive. In pregnancy, we have guanfacine and guanabens, apraclonidine. All these ones are there. Then we have the beta agonists. We have the selective and the non-selective ones. And we have salbutamol, which is used in asthma. We have terbutaline, formoterol, and salmeterol. All of these ones are bronchodilators. They are used in asthma. Then we have isoproterenol or isoprenaline, which tend to bind to both beta 1 and beta 2 receptors equally. Then there is mixed agonists. We have ephedrine binding to all three receptors, and it also has a releasing action. And then we have epinephrine binding to all three receptors. No, epinephrine does not bind to the beta 3 receptors. Then dopamine also binds to D1 receptors and sometimes alpha 2 and then beta 1 receptors. Then we have D1 phenodopam. This is something I told you to remember. Okay, so this is a mind map. You can use it. For antagonists too, we have alpha 1 antagonists, all of them end in sin, prazosin, terazosin, tamsulosin, you want to remember. Okay, then we have the alpha 2 receptors. Yohimbine is the main agent. Then we have the beta 2, beta, we can have first generation, second generation, and third generation. First generation, we said that they were the ones that start from N to Z, nadolol, propanolol, pentothal, timolol, sotalol. Then the second generation ones are tinolol, bitazolol, bisoprolol, esmolol. They start from A to M. Okay. Then the third generations, we have those that have other activities like labetalol and then carvedilol. Remember we said that they also bind to the alpha receptors. Okay. Nebivolol, what did we say about it? It causes nitric oxide release. And those with intrinsic sympathomimetic activity, we have acebutolol and pindolol. So they are partial agonists. All right, thank you very much.